and we're going to talk about both isolation and retraction resources. And I bring up, isolation resources because those are the ones that tend to hold the cheeks, the lips, and the tongue out of the way. But they are outside, generally, of our restorative field. But it's important to include isolation in our conversation about retraction because the anatomy that drips the saliva and oral fluids into our restorative field does, in fact, need to be contained, retracted, and addressed. We can dry the tooth surface all we want, but if we don't contain the moisture from the rest of the oral cavity, our efforts may very well be in vain. So pictured here, we have a couple of isolation items. So these kinds of devices work by attaching a flexible silicone mouthpiece to the high volume suction line. They can be inserted into the patient's mouth, repositioned, taken out for a restroom break, flipped to the other side to do the right and left sides of the mouth, and retract the tongue, the cheeks, the lips, and act as a throat pack all in one fell swoop. Dry Shield's product has the benefit of autoclavable mouthpieces to decrease overall practice waste. It can keep your disposable overhead low and comes in multiple sizes. Isolite system on the other side here also comes in multiple sizes, all the way from pedo to large, including a deep vestibule option for patients that have a bit more vertical space intraorally. Rubber dam isolation of the arch also lends itself to extremely effective soft tissue retraction, not just of the tooth itself, but also keeps those lips, tongue, and cheeks out of your way to allow for excellent visibility and control of the restorative field. Now, do I love a rubber dam for the occlusal of a third molar? Not always. In those cases, I may opt for a disposable isolite trimmed in the vestibule or the palate as needed to allow the patient to bite down a little bit more and gives me a little more elasticity in the cheeks that allows for me to retract manually and see what I'm doing efficiently for me, but also safely for the patient. When we get to the tooth level, we need to consider both mechanical and chemical means for decreasing moisture and keeping the soft tissue and moisture out of the way. On the mechanical side, we've got cords, specialized instruments, matrices of all shapes and sizes, and physical removal or recontouring of the tissue. On the chemical side, we have both astringents and hemostatic agents, and some that do double duty. The use of various retraction options for a direct, deep, and far-reaching Class 5 carious lesion. Initially, an Ultradent cord size 00 was used for retraction of the tissue with a flat cord packing instrument. Then Voco's retraction paste was placed. Note the paste bright blue color makes it easy to visualize, and the setting time of 1 to 2 minutes allows for an efficient, streamlined workflow. As the material begins to set, the viscosity changes. It becomes a bit more firm, and it pushes a bit on the tissue to mechanically retract the tissue in addition to using its chemical astringent qualities. The retraction paste was rinsed off, and then a Toffelmeyer matrix was trimmed and placed sort of scoop side down into the gingival sulcus, gently pushing the gingiva out of the way and secured with a pair of wedges. All of this was completed under isolite isolation as well. Final restoration is pictured here on the right. Heated composite was placed and finished and polished with a disc using an upward sweeping motion to, again, not abrade the gingival tissue. Here's the final restoration, and we used an isolite, retraction cord, retraction paste, matrix band, and a wedge.